How do you think your body keeps track of proteins, processes toxins, and manages nutrients without missing a beat? It's all thanks to your liver, a silent workhorse with a portfolio more impressive than most CEOs. In today's video, we're diving into part 2 of our liver function series, focusing on the liver's synthesis and metabolic functions, critical roles that are often underestimated yet absolutely essential. We'll answer key questions like: what exactly does the liver synthesize, and why does it matter in disease? How does it manage substances like ammonia, glucose, and fats? And how can lab tests clue us into when something goes wrong? If you're preparing for the ASCP exam or just trying to grasp the clinical relevance of hepatic function, this video will not only help you understand the what, but also the why behind it all. We'll connect lab values to physiology, and physiology to pathology, with real clarity. And by the end of this video, you won't just memorize facts, you'll be able to think like a clinical scientist, interpreting data with confidence. Let's break down the complexity of hepatic synthesis and metabolism into something simple, sharp, and unforgettable. The liver is not just a filter, it's a full-scale biochemical factory. One of its most vital responsibilities is synthetic function, producing the essential proteins and molecules that keep our bodies running. Let's break this down, starting with an overview. The liver plays a central role in metabolism, processing proteins, carbohydrates, and lipids. Nutrients like glucose, amino acids, and free fatty acids pass through hepatocyte membranes in both directions, depending on the body's needs. To maintain blood glucose levels, the liver responds in 2 phases. During short-term fasting, it breaks down hepatic glycogen. During prolonged fasting, it activates gluconeogenesis, creating glucose from amino acids, primarily drawn from muscle protein. Other gluconeogenic substrates include lactate from muscles and red blood cells, glycerol from triglyceride breakdown, and odd-numbered fatty acids, though they contribute minimally. But glucose isn't all it makes. The liver also synthesizes proteins, triglycerides, fatty acids, cholesterol, and bile acids, supporting everything from cellular structure to digestion. Now let's zoom into protein synthesis. Most plasma proteins are synthesized in the rough endoplasmic reticulum of hepatocytes and then released into the bloodstream. But several factors can impact plasma protein levels. Liver function impairment, of course. Nutrient deficiencies due to malnutrition or malabsorption. Catabolic states like hyperthyroidism, burns, or surgical recovery. Conditions causing protein loss, like nephrotic syndrome or protein-losing enteropathy. Cytokines play a role too, lowering albumin and transferrin but increasing inflammatory proteins like alpha-1 antitrypsin and ceruloplasmin. Hormones also influence production, growth hormone, cortisol, estrogen, and androgens. And we can't forget genetic disorders, such as Wilson disease and alpha-1 antitrypsin deficiency. Despite these factors, the liver has a large protein reserve. So protein levels remain stable unless liver damage is severe. Importantly, long half-life proteins, like albumin, which lasts around 3 weeks, aren't great for diagnosing acute liver disease. Let's talk about how these proteins change in disease. In acute liver dysfunction, total plasma protein levels may show minimal changes. But in severe injury or fulminant hepatic failure, proteins with short half-lives, like transthyretin and prothrombin, drop quickly, while long-lived proteins change little. In cirrhosis, liver-produced plasma proteins decline, while immunoglobulins often increase. A critical prognostic marker here is prothrombin time. Worsening PT in acute hepatitis can signal a poor prognosis. Now, let's dive into individual plasma proteins synthesized by the liver. 1. Albumin. Albumin is the most commonly measured plasma protein, and it's produced only by the liver. Its synthesis is influenced by hormones, nutrition, age, and other local factors. Inflammatory cytokines like interleukin-6 decrease albumin production while increasing acute phase proteins. In liver disease, hypoalbuminemia occurs mainly in cirrhosis, autoimmune hepatitis, and alcoholic hepatitis. Interestingly, albumin production in cirrhosis may be normal, increased, or decreased, but loss into acidic fluid often contributes to low serum levels. There are also measurement caveats. Bromocresol green may overestimate albumin at low levels. Bromocresol purple can underestimate albumin in jaundiced patients due to bilirubin interference. 2. Transthyretin. Transthyretin, with a half-life of only 24 to 48 hours, is a sensitive marker for acute changes in protein production. It's typically decreased in cirrhosis and is more often used to assess nutritional status than liver function. 3. Immunoglobulins. While not produced by hepatocytes, immunoglobulins often increase in chronic liver diseases. For instance, IgG is elevated in autoimmune hepatitis and cirrhosis. IgM increases in primary biliary cirrhosis. IgA is elevated in all forms of cirrhosis. However, since these changes aren't specific to liver disease, they're rarely used for diagnosis. 4. Ceruloplasmin. Ceruloplasmin, a copper-carrying protein, is decreased in Wilson disease, cirrhosis, and chronic hepatitis. It increases with inflammation, cholestasis, hemochromatosis, pregnancy, and estrogen therapy. 5. Alpha-1 antitrypsin, AAT. AAT is a major serine protease inhibitor. It's decreased in homozygous deficiency and cirrhosis, but increased during acute inflammation. It plays a key role in protecting tissues from enzyme damage. 6. Alpha-fetoprotein, AFP. AFP is a fetal protein that normally drops to adult levels by age 1. Slight elevations may indicate liver regeneration in acute or chronic hepatitis, but high levels strongly suggest hepatocellular carcinoma. Now let's move on to coagulation proteins. The liver synthesizes nearly all coagulation factors, as well as anticoagulants like antithrombin, protein C, and protein S. Several of these, including factors 2, 7, 9, 10, and protein C and S, require vitamin K for activation. For example, protein C helps inhibit coagulation by inactivating factors V and 8. In severe liver disease or obstructive conditions that reduce vitamin K absorption, coagulation is impaired. However, bleeding disorders generally emerge only in advanced or long-standing disease, thanks to the liver's large functional reserve. Now, how do we assess this clinically? We use prothrombin time, PT, to measure clotting function. PT reflects activity of fibrinogen, factor 1, prothrombin, 2, and factors V, 7, and 10, all liver-made. PT can be prolonged for several reasons. In cholestasis, reduced vitamin K absorption results in correctable PT prolongation, usually fixed with a 10 mg vitamin K injection. In hepatocellular disease, factor synthesis is impaired, and PT doesn't correct with vitamin K. In dysfibrinogenemia, abnormal fibrinogen leads to poor clotting, and even thrombosis. Because PT results vary by lab and reagent, the International Normalized Ratio, INR, was developed to standardize results, especially in patients on warfarin. However, INR has limitations in liver disease. Warfarin causes buildup of PIVKAs, non-functional clotting factors that inhibit coagulation. In contrast, liver disease causes a true deficiency in clotting factors without producing PIVKAs. This difference means INR can underestimate bleeding risk in liver disease. Research is exploring a liver-specific ISI to improve PT interpretation, but it's not widely used yet. Finally, let's explore lipid and urea metabolism. The liver plays a huge role in lipid metabolism, especially handling fatty acids and cholesterol. About a third of daily fatty acids from adipose tissue go to the liver. In fasting, fatty acids are oxidized for energy. In fed states, they're esterified into triglycerides. Too much esterification. That can lead to fatty liver, where triglycerides build up inside liver cells. Cholesterol, mostly synthesized in the liver, is used for bile acid production, lipoprotein formation, and cell membrane maintenance. An imbalance in bile acids, cholesterol, and lecithin can contribute to cholesterol gallstones. And what about ammonia? As a toxic byproduct of protein metabolism, it must be removed. The liver handles this through the urea cycle, converting ammonia to urea, which is then excreted in urine. In end-stage liver disease, urea synthesis decreases. Plasma urea levels drop. Urinary urea excretion falls. Ammonia and amino acid levels rise, and reduced urea cycle enzyme activity leads to impaired nitrogen metabolism. Urea production depends on dietary nitrogen intake, and endogenous protein breakdown, or catabolism. The liver, our body's central metabolic hub, is not just another organ. It's a highly specialized control center, responsible for a wide array of metabolic and regulatory processes that keep us alive and functioning. In this section, we'll explore the liver's critical role in drug metabolism, ammonia detoxification, carbohydrate processing, xenobiotic clearance, and storage of essential energy substrates. Let's start with the liver's metabolic role. The liver is essential in drug metabolism, both in activating toxins and activating medications into their usable forms. It also breaks down various exogenous substances, like galactose, and endogenous byproducts, such as ammonia. When liver metabolism fails, it can be deadly. For instance, in galactosemia, a genetic disorder where a key enzyme is missing, galactose builds up in the blood. This accumulation damages the liver, brain, and kidneys. Ammonia metabolism. Ammonia is one of the most toxic byproducts in our body. It primarily originates in the gastrointestinal tract, where bacteria break down proteins. Under normal circumstances, the liver steps in and transforms this ammonia into urea through the urea cycle, allowing it to be safely excreted in urine. However, if the liver falters, ammonia accumulates in the bloodstream and reaches the brain. This happens via passive diffusion, and under higher pH conditions, more ammonia crosses the blood-brain barrier, increasing the risk of neurotoxicity. Clinically, elevated ammonia levels, or hyperammonemia, can trigger hepatic encephalopathy, a serious brain dysfunction. It can arise from inherited enzyme deficiencies in the urea cycle, acquired liver conditions like cirrhosis or fulminant hepatitis, where ammonia clearance is impaired, kidney failure, which increases urea breakdown in the gut, and rare syndromes like Reye syndrome, which hits both the brain and liver. There are also specific triggers of hepatic encephalopathy, including gastrointestinal bleeding, high-protein diets, constipation, infection, CNS depressant drugs, electrolyte disturbances, and portosystemic shunting, where blood bypasses the liver entirely. To diagnose these conditions, we rely on plasma ammonia testing. It's valuable for identifying Reye syndrome, urea cycle disorders, and evaluating acute liver failure, where levels over 200 micromoles per liter are linked to poor prognosis. However, in chronic liver disease, ammonia levels don't always correlate with clinical severity, limiting their diagnostic value. The most common testing method is enzymatic, using glutamate dehydrogenase. But be warned, these tests are very sensitive to sample contamination, which can lead to misleading results. Normal plasma ammonia levels range from 15 to 45 g/dl or 11 to 32 micromoles per liter, but always check lab-specific reference values, especially in pediatric patients. Carbohydrate metabolism. Beyond ammonia, the liver is pivotal in handling carbohydrates, both from our diet and those produced internally. It stores glycogen and performs gluconeogenesis, helping maintain stable blood glucose. In severe liver conditions like Reye syndrome, fulminant hepatic failure, advanced cirrhosis, or hepatocellular carcinoma, HCC, this function can collapse, leading to hypoglycemia. Unfortunately, traditional carbohydrate metabolism tests aren't helpful in diagnosing liver disease directly. Xenobiotic metabolism and excretion. Xenobiotics are foreign substances introduced into the body, like drugs or toxins. The liver processes these using its complex enzymatic systems. While they can provide insight into liver function, these tests are less reliable than standard liver function markers like bilirubin, albumin, and INR. In fact, liver function tests based on xenobiotic clearance often show a gradual decline in late-stage liver disease, but results overlap in patients with both mild and severe liver fibrosis, limiting their clinical utility. Dye excretion tests. Although now mostly obsolete, dye excretion tests were once a cornerstone in liver function assessment. Bromsulfalane, BSP, was the most common, but its use was discontinued after reports of severe allergic reactions. Today, indocyanine green, ICG, clearance is occasionally used, especially to evaluate hepatic blood flow and drug metabolism, such as for lignocaine. Normal ICG clearance ranges from 6.5 to 14 milliliters per minute per kilogram. Drug clearance tests. The liver's ability to metabolize drugs through its cytochrome P450 enzyme system can be studied using specific drug clearance tests. 1. Aminopyrine breath test. This test uses 13C or 14C labeled aminopyrine, which the liver metabolizes, releasing CO2 detectable in breath samples. Although promising, its accuracy is influenced by smoking, oral contraceptives, and individual metabolism variations. 2. Caffeine clearance test. Caffeine metabolism slows in conditions like chronic hepatitis and cirrhosis. After administering a 3.5 mg per kilogram dose of caffeine, max 200 mg, clinicians measure caffeine levels via blood or saliva samples, using HPLC or immunoassays. In healthy adults, caffeine has a 5.5-hour half-life, with a clearance rate of 2 milliliters per minute per kilogram. In children, half-life is 3 hours, and clearance rises to 10 milliliters per minute per kilogram. This test is less impacted by external factors than the aminopyrine breath test. 3. Lidocaine clearance test. Lidocaine is metabolized by the liver into MEGX, monoethylglycinexidide. After injecting 1 mg per kilogram of lidocaine, MEGX levels are measured at the 15-minute mark using an immunoassay. This test is especially useful in post-liver transplantation assessments, although it can be affected by conditions like sepsis or dehydration, which reduce blood flow to the liver. Hepatic storage function. Lastly, the liver functions as a massive storage unit for energy-rich molecules. It stores glycogen, which serves as an immediate glucose reserve during fasting or low-carb states. Other tissues like muscles and adipose tissue also store nutrients, proteins and triglycerides, respectively. These systems are highly adaptive and can switch between storage, release, or synthesis modes depending on our nutritional state and energy needs. You've just unlocked the fascinating world of hepatic synthesis and metabolic functions, from the liver's incredible role in plasma protein production to how it masterfully handles ammonia detoxification, glucose regulation, lipid processing, and drug metabolism. Let's quickly recap. The liver is not just a digestive organ, it's a metabolic powerhouse, a biochemical factory, and a detox expert. Its ability to synthesize vital proteins, convert harmful ammonia into urea, maintain glucose balance, and regulate lipids is absolutely essential to life. For ASCP students, understanding these liver functions is crucial. It's the key to interpreting lab values, diagnosing complex hepatic disorders, and appreciating the depth of biochemical interactions behind clinical symptoms. If this video helped clarify even one tough concept for you, do us a favor, like this video, subscribe, and hit that notification bell so you don't miss the upcoming parts in this liver function series. Your journey to mastering clinical chemistry just got a serious boost. Thanks for watching, and stay curious, stay confident, and keep learning.